the simple admission that this is the deal, that this thing exists and it affects our clinical work would be a huge step forward. Unless we can be real about it, we can't really make correction.
Welcome to Psychiatric. I am Dr. O'Leary, and today is Sunday, June 30th, 2024. This is a podcast about psychiatry and neuroscience, and sometimes psychology or psychotherapy. I am a fellow in child and adolescent psychiatry in the National Capital Region. In fact, I just started my fellowship. I make this podcast as a way to explore topics that I find fascinating and to share that wonder and excitement with you. Today, I have the pleasure of presenting an interview with Dr. Alexey Tolchinsky, a clinical psychologist who happened to listen to one of my episodes and then emailed me a response. He recently published a paper called Narrative Fallacy and Other Limitations of Psychodynamic Case Formulation. Dr. Tolchinsky did not invent the idea of the narrative fallacy, which he will explain later, but he is working to apply this idea to his own clinical practice and to help other clinicians apply it to theirs. I really feel like we could all benefit from recognizing the ways in which the narrative fallacy plays out in our lives. And the great thing about these ideas is that they're so generalizable. I mean, the narrative fallacy is not limited to medicine or to science or psychology, but it can be applied, for example, to how we explain to ourselves why our neighbor seems to hate us. Now, I don't want to waste any more of your time, so let me get to the interview. Alexey, welcome to Psychiatric. It's great to have you on. I started emailing with you a few weeks ago, and we found out we're kind of interested in a lot of the same things. I'm a psychiatrist, and you are a psychologist. Is that correct?
Yes.
And so I'd just like you to introduce yourself to the audience here. Tell them a little bit about your journey to become a psychologist and then why you became interested in what we're going to talk about today.
Thank you for having me, Ryan. I enjoy listening to your podcasts. I really like several episodes about the Bayesian episode, and I was listening to your dopamine detox one yesterday with great pleasure, and it's a pleasure to be here. I'm a clinical psychologist in private practice in Maryland, in Montgomery County. And I work in outpatient settings, so I see people with anxiety disorders, trauma. I see a lot of immigrants, mood disorder, psychosis. I've graduated and I got licensed in 2015, so 9 years ago. And my journey was long to psychology. I graduated from Moscow Institute of Physics and Technology, so I was studying physics first. Then I was working in IT, being a IT engineer for about 18 years or so. And then I was getting bored, and part-time I was working as a photojournalist. I was doing some assignments as a freelancer for the Washington Post. And then I realized that it wasn't the light and the composition that interested me most. It was people, And at that time I was in therapy myself. But that realization led me to a professional psychology program at GW in DC, and I love our program, so I definitely don't regret that decision, and the rest is history.
Seems like we have something in common because I came in late into medicine. Well, first dropped out of college and then came back to college, got a degree in evolutionary biology, then a master's in evolutionary biology, did most of my work in phylogenetics, and then kind of took a break after that, then went back, then joined the military, then went back to school. So we both came to our fields in a very roundabout way, sounds like. And I guess, with that, if that's the case, then you have a lot of a life experience that you kind of brought with you before you got there. And that probably had some influence on how you think about psychology and your relationship with your patients. So today, I would like you to talk about this thing called the narrative fallacy, because you published a paper on it in its Practice Innovations in 2023 called The Narrative Fallacy and Other Limitations of Psychodynamic Case Formulation. But I think the narrative fallacy isn't just limited to limitations of psychodynamic case formulations. It's much more broad than that. So can you just explain a little bit about how you became interested, or what the narrative fallacy is, how you became interested in it?
Mm-hmm. So I wanted to say that this term is the two words together is a specific technical term, because people start thinking it's about narrative theory. or it's about fallacy, and it's neither. I picked up the term from Nassim Taleb. I was reading his famous book, Black Swan, and he's an interesting writer to read. His style is sort of off-putting a little bit, to me at least. He's an angry writer. Like, he's very upset with, I don't know, Harvard and academia, while he actually went to Wharton. But he's making good points, and the late, great Daniel Kahneman liked Taleb's points. And one of the things he talked about is narrative fallacy, which simply means that we have a hard time as human beings looking at a sequence of facts or events or data points without connecting them together. We tend to connect the dots, whether we like it or not. It takes a lot of effort not to do so. And that's just a description of the phenomenon. But we see it broadly in all sorts of circumstances. If you'd like, I can illustrate it for your audience experientially as an example.
Yeah, please. Yeah, absolutely. Please do that. Yeah.
So I would ask our listeners, I realize people may be in the car or something, but just to do this with me, I'll give you a few words. Try to retain them in your memory. I'll just read them to you and just try to hold on to them. Okay? Magnolia, Club, 1964, Firefighters, Chicago, Jazz, Winter, 10.
Well, that's a lot of things.
That's a lot of things.
Yeah, I give a test frequently called the MOCA, and I have people memorize a list of, I think it's 5 things. And then I have them repeat back, and then they do it again. And then a few minutes later, I test them. But this is much more difficult, what you just asked us to do.
What I wanted people to feel is that there's a little bit of strain. And what you shared with me is the thing. It is hard for us to keep things that seemingly don't have anything to do with one another. I'll present the same exact words in a different form. On a cold winter day in 1964, a jazz club, Magnolia, in Chicago, caught on fire. Firefighters were on the scene within 10 minutes.
Yeah, suddenly I have a narrative, right? I can go through it. This is similar, I think, to some time when I've listened to people talk about them being able to increase their memory. One of the things that they do is they either draw a picture or they tell a story of whatever it is they're supposed to remember in their mind, and it helps them to take information that seems like longer and maybe make it less easier to deal with. Can you comment about that a little bit?
Yeah, so this example isn't mine. It's partially modified from Arban's repeated battery of neuropsychological assessment that people do in neuropsych evaluations for, a broad sort of, look at many symptoms. And the second example is a piece of prose, couple of sentences. The first one is a random list of words. Typically, people do better with prose, except for certain disorders. And there's reasons for it. Is there's redundancy in the speech. There is expectations that we have. Like when I say on a cold winter, the word day is coming. 1964 we grab as one chunk. It's contextualized. And it is a lot easier for us to retain the piece of prose. It also makes sense because, I told you the second part of the story flows from the first one temporally. The firefighters showed up to the fire. So there are a lot of things in the second presentation that makes it much more digestible for us.
It's almost as if each of those words, even though you made them part of something bigger, that thing that was bigger was still just one thing and actually easier than some random word to memorize.
Yeah. And it had a certain quality to this narrative that made it easier to memorize. It was coherent and it was meaningful. Had it not been so, it would have been, if you give these 2 sentences to somebody who doesn't know English, then they would have equal difficulty with that, perhaps. So, but this example is artificial. The only thing I wanted from it is to feel the strain of holding in memory the unconnected dots. And this is exactly, the point. So outside of this example, if we table it entirely, as I'm talking to you right now, Ryan, or if I'm doing anything in my life, I connect the dots automatically, preconsciously or unconsciously, all the time. We do it all the time because I think the reason for that is our working memory is a very small space, and it is just simply not possible for us to retain all the bits of information through all the senses coming at us. And so we do some cognitive heuristics or habits, if you wish. We chunk things together like area codes and phone numbers. We use our memory banks to process what's coming at us. This is a very interesting thing where we use our long-term memory to make sense of what's coming and to sort of digest it. And we see those of us who are parents see it beautifully in young children who learn to read. I have a 7-year-old, and she's reading in 2 languages, in Russian and English. Russian is a little behind, and when she reads a word in Russian that she doesn't know, she reads phonetically, which is effortful.
Right.
She's very fluent in reading in English now. She sees a word that she knows, boom, very quickly. So this is an example of sort of using long-term memory for processing of incoming information. Long story short is, as clinicians, if we move into clinical practice, when we hear a patient, we do the same thing often without realizing it. We connect the dots. And maybe if I give you an oversimplified example that wouldn't resonate with many people, but say we're doing an intake, first meeting with a patient, and a lot of information is coming at us. And we hear that they have sleep difficulty. Perhaps in our head, we classify it as both a sleep onset insomnia and sleep maintenance insomnia. And then later through the narrative, you listen and hear that it appears that they have a dysregulated anxiety, that they have an anxiety disorder, they worry all the time. What I don't know about you, but in my head, the possibility of these things connected would happen. I'd have a hypothesis that anxiety could possibly be one of the reasons why it's hard for them to fall asleep specifically.
Right. So we tell ourselves that story. You have anxiety, so you can't fall asleep because you're worrying about something, and that's what's keeping you awake. Another way to look at it is maybe like pattern recognition. You see things that seem to fit into a pattern that you've already pre-built in your head to help you understand the world.
Right. I spoke to one of the wonderful specialists in sleep in this area. She retired recently, Helen Solomon, and she said, look, I may not tell you exactly why you're not sleeping. You may have 7 different reasons at the same time: vitamin D deficiency, endocrine factors, a lot of different things, and anxiety could be one of them. But if there's something concrete and special like apnea, we can nip it in the bud and talk about it. But if you want a full explanation, of why exactly, you have a certain sleep issue, it may not even be possible to answer that question. But we don't think like that really in clinical practice, because it's not possible. We have a job, there's a limited time, and the patient wants some answers to the question. So we try to make sense of information coming at us by sometimes connecting the dots.
Yeah, well, absolutely. When I remember I had a whiteboard in my office for a year before I had to change offices. I loved it because I could get up, I could tell a patient, well, your symptoms are consistent with, say, for example, depressive disorder. And then I can get up on the board and I could either draw a picture. I'd love to draw a picture of the brain and then kind of point to parts of the brain that might be, you could say, malfunctioning in the disorder. And I try to explain it to them by giving them this sort of narrative, I guess you could call it, this, or these tools to think about it in a way that was a little bit maybe more separated from the actual symptoms that they were experiencing explicitly, but that there's something actually happening to them and we can work to fix that. I tried to be vague enough that I wasn't telling them exactly, I knew exactly what was going on with them, but I just wanted to give them something to help them to process what I was trying to say to them.
I really like how you put it, Ryan, and I think it's important. Now we're moving to the sort of psychological aspect of the work. Is patients often come to us in distress. They don't come here for sports. And one of the things they want, many things they want, but one of them is to fill in the explanatory gap. Something doesn't quite make sense. They don't know why often. To give a concrete neurological example, when the patient, the anecdote is that a competent neurologist can suspect Parkinson's before the patient walks in the door because they hear the shuffling outside the office. Then the patient walks in, you see, rigid posture, difficulty initiating speech, you see rolling pin tremor, cognitive slowness, and you put all of that together and you have a hypothesis of a Parkinson's disorder.
Oh yeah, absolutely. Yesterday at the store, I saw someone using a cart to kind of hold themselves up. They were shuffling, like they weren't barely bringing their feet off the ground, just sort of sliding them forward, very small steps, holding themselves, leaning a little bit forward, looked kind of rigid. And I'm like, they probably have Parkinson's.
Right.
Yeah.
But so patient is knocking on the door, perhaps with their wife or family, and they don't know what's up yet. They may read Google, Dr. Google, whatever, but they don't know. And then when the neurologist says that, I suspect Parkinson's disorder, and then they'll do the examination and test to try to confirm or rule out this hypothesis. We filled in the gap with an explanation. And what did we fill it with? With what we have been taught. Neurologists have a vocabulary, they have a, extensive experience and knowledge. They fielded from the theory that they've studied on sort of the whole etiology, nosology, pathology of Parkinson's, and sort of this presentation. They recognize the pattern. But I'm saying this is often where the explanation comes from, what we have studied. So if, for example, I have been taught that, depression is a disease, story number one, not a state like fever, but a disease like malaria or flu, and B, that depression is caused by chemical imbalance, then this is how I will be likely to explain depression, right? And then I may be likely to prescribe a certain medication that corrects the chemical imbalance, such as that if my story is that it's low level of serotonin, then I might prescribe the selective serotonin reuptake inhibitor.
Right. Socially, this idea of chemical imbalance is very powerful. I think it started in like the 80s and in the 90s became very much like almost set in stone, even though there wasn't a whole lot of actual evidence for it. It was just such a great story that it could perpetuate itself almost. And now on TikTok, we have people who are kind of using that same kind of narrative to talk about things like dopamine and the serotonin, and they're talking about these molecules as if they have some special power. And then recently in Nature, there's a paper published saying that this monoamine hypothesis, or the serotonin hypothesis of depression, analyzing the evidence and showing we didn't really have that much for that sort of formulation of how depression comes about in the brain.
Right. And, just for the record, I'm not saying the SSRI is somehow bad or inefficient. I'm definitely far away from the anti-psychiatry people. It's a chemical agent, but even the invention of the term antidepressant was already programming by language. Because when you say SSRI, people don't react. When you say antidepressant, that implies there's a clear-cut thing right there in the brain, a little to the left from like insula, called depression,
Mm-hmm.
And then if you take that pill, then it's supposed to take care of depression. Now, when that doesn't work, you know what I'm going to do? I'm going to call you depression treatment-resistant depression, because it's supposed to, by the very name of it, antidepressant, right? And then, okay, the literal definition of treatment-resistant depression is no response to 2 SSRIs. Okay. Now, then what? Then electroconvulsive therapy. That didn't work. Ketamine didn't work. Surgery.
Right. Yeah.
There's a collection of stories coming together. And, I'm joking a little, but people definitely work this way. Treatment-resistant depression is not questioned as a construct.
Yeah, I'll challenge that it's not questioned as a construct a little bit, because in our academics a few weeks ago, we were discussing treatment-resistant depression, it specifically, and I asked people to really come up with an actual definition of what it was, and no one could. And so, it's kind of pointing out that because there are multiple different definitions, it's like what a treatment failure is, or I wanted to point out in that academic session that what we're doing is in so many ways arbitrary. It may be based on some fact, something real, but it's in the end, we're just kind of making stuff up and hoping that it sticks, hoping that it works.
Yeah. I enjoy when you challenge me. Please do. I this is how I digest material myself, and I'm glad you do. It's just I'm saying mainstream. We wouldn't have ketamine clinics pop up, in every corner like Starbucks, if the story of treatment-resistant depression was not entrenched. But to illustrate the story, was the this is Lawrence Kiermaier quoted in the book, Mad in America, but there was no word in Japanese language for moderate depression. There was no word in the language, and the prescription of SSRIs were zero in the 1990s, while worldwide they were, the market was $13 billion worldwide market. So GlaxoSmithKline showed up. They did a marketing campaign. They invited Professor Kiermaier, and they treated him very well. There was luxury hotels, first-class ticket, whatnot. And they investigated this sort of cultural influence on this thing. And then they launched a marketing campaign containing 3 messages. Depression is a common disease, message number 1. It is caused by chemical imbalance, number 2. And we have a cure for it called Paxil. By 2008, their revenue reached $1 billion a year from zero.
Yes, so, and this narrative that being sold by people who could really benefit from having that narrative become part of people's culture. Especially such a simplified narrative really helps them out. There's less room for people to really question things. if
Yeah.
stuff seems so straightforward, Yeah.
But I drifted away. Please forgive me. I want to go
That's
back.
okay.
Very important. You said that when you talked about your patient and you had a thought about depression and you tentatively and carefully shared this idea with them, maybe showed them the brain and other things. And then it looks like the patient felt some comfort from listening to it.
Yes.
This is another danger that we're talking about. And sometimes it's necessary and they want to feel comfort. They want to get some kind of what's going on, right? And the danger is called the Forer effect or Barnum effect. And what it simply means is that when the patient feels resonance from what they hear from the doctor, this is no indication about the truth at all whatsoever. We can feel resonance when the data is off. And, a lot of people feel resonance in astrology sessions, very powerful resonance.
Yes.
What Forer did in 1949, I believe, is he gave 50 students questionnaires, personality questionnaires, which they diligently answered, gave him the answers. Then he mailed them. Back in the day, it was snail mail. He mailed them the results, which were identical to every person, and he took them from the astrology book, and he asked them to rate the accuracy of the narrative. And they rated it 4.5 on a 1 to 5 scale.
Wow. This is not surprising, actually.
Right.
Well, for me, I think because I've read so much similar things, but I think for the general public, yeah, that would be something that might seem a little shocking.
Right.
Yeah.
And I experienced that, and I was, it's also pleasant for us as clinicians to experience resonance of the patient when we did something good here. And when I was doing psych testing, I don't do it much anymore. And we have a part of psych testing about personality, which is written like a narrative. And it's based on a lot of data and projective testing, Rorschach and cognitive testing, but we put it together as a story. And sometimes I had this sort of awe in the room where the patient looks at me and is like, how do you know that about me? Are you a magician? Are you like, what's going on? And I'm like, pause this right now. Take what I'm saying to you with a truckload of salt. You feeling these goosebumps and this resonance does not mean that I'm right. These are all hypotheses to be tested. Yes, I have 4 different tests pointing in one direction, but please be critical. But they want to feel that, so, and it is seductive, also in therapy session, you say something, patient cries, and we think, yep, we got it. We're on it. This is the deal, but we don't know if it is. So this is the difficulty in how we test the hypothesis. Often it's patient's reaction, but them saying, oh yeah, that resonates a great deal is good to hear. It's data, but it doesn't mean that what we said was right. So
I guess this relates to the transference, countertransference ideas, right? About how you perceive the patient and how you think the patient is perceiving you in light of maybe their past or their beliefs or recent experiences that they have had with other people. There could be any number of reasons why today they're doing the thing that they're doing, and we don't necessarily know why that is.
Yeah. And before we even get to sort of this patient reaction as a guide, whether we were right or not, if we talk about how we formulated the hypothesis, oftentimes it's formulated in a form that is not falsifiable. Whatever we do, whether we do psychodynamic therapy, whether we do CBT, EMDR, or psychiatry, what we tell the patient as to why something is, and I'm being trivial, but, water boils at 100 degrees Celsius under normal pressure is a falsifiable statement. But, you feel hopeless because you have a chemical imbalance in your brain is not a falsifiable hypothesis, So, or if I say that there's, dysregulation of the panic system and, they have separation anxiety, what I tell them some things and strictly scientifically, it's not possible to truly, falsify in this hypothesis. So this is sort of what I wrote in the papers. Our methodology, we think we're hypothetically deductive. We had 3 hypotheses and we're testing them with more incoming data coming up. But first of all, quite often these hypotheses are not truly falsifiable. And secondly, if we rely on data such as patient's resonance, then we're prone to Barnum effect. And lastly, there's effort justification. It takes a bit of work to listen to the patient carefully, put things together, and to share with them what we thought. And if we invest energy into a hypothesis, it's not that easy to let go of it.
Yeah.
I
can relate to that for sure. Yeah.
So these are just some of the things I said. But in full disclosure, I'm not sitting on a high horse, judging colleagues and saying, oh, I'm doing it right and you're doing it wrong. I am prone to it just like anybody else. These are human things. And what I'm inviting my colleagues and to consider is that this is reality. This is part of our work. And if we're honest about this challenge and we do certain things to mitigate its effects, then we can just simply do things a little bit better. That's all. But I don't think anybody's immune from it, no matter how experienced they are. People often say in training, Alexey, what you're saying is trivial because we tell people not to jump to conclusions. Collect data, collect data, collect data. Okay. But first of all, we think they're not jumping to conclusions, but they are, because this is the way working memory works. It is simply not possible to be passive and to put things on the shelves. It is that's an illusion that we actually are able to do that. Even if it's preached, I don't think it's practiced. But also,
or even could be practiced.
Right.
We can't be a passive observer. That's impossible. Yeah.
And nor do I think it's a good idea, because we'll have a combinatorial explosion. If every single tidbit that the patient is sharing, I'm treating as independent piece of data, I'll blow up. There's no way to think in the room, right?
Right. Too much energy required to connect. Yeah.
So we must, generalize. We must think. We must connect. But if we know that, narrative has a certain limitation, and the reason I'm saying it, Ryan, is in my world of psychodynamic psychotherapy, we have this concept case formulation, and I found some papers in psychiatric case formulations that have a slightly different methodology. I think there's 4 Ps or 5 Ps in psychiatric case formulation: prior history and predisposing factors, and and other Ps. But we have textbooks, wonderful textbook by Nancy McWilliams, who is sort of widely cited, and other things. But at the end of the day, traditionally, it's a story. It's a few paragraphs of text where we tie things together, and it makes some sense to the patient and to us.
I'm reminded of what they teach more in psychiatry, like starting in med school, something called the biopsychosocial formulation, which, of course, in medicine, they want you to focus on the bio. We're supposed to have some sort of insight into that because of, our medicine's background, especially. They refer to it as a model. And so one of the things that I sometimes get on my high horse about around other residents is it's not a model because it predicts nothing. Models are things that you put in certain information and they have a process of creating some sort of probability and they spit that out and they predict something. But this is not a model, it's a formulation where we just try to make sense of this patient and we consider certain factors that we are told are probably have some importance.
Yeah. So to bring it home, if you want, I had a paper that I just found where it's a paper on how to do psychiatric case formulation, a little dated, it's from 2007, but I think they did a great job. It's very thorough, and it is biopsychosocial. I agree with you. I think it's a marketing term, biopsychosocial, and I think that there's diversity police in the room where they're like, you guys are just biologists, you're reducing everything to serotonin, look at the sort of, cultural factors and other things. And then we're like, well, let me describe in paragraph number 1, bio, here I'm going to describe social, here I'm going to describe psychological, and then I'm done. And you can also go the route where you just consider so many factors ad absurdum, like biopsychosocial, cultural, spiritual, economic. You can add as many as you want, right? And
I think we know by math, it's just things like, I'm going to get a little nerdy right now, but things like principal components analyses and things where you look at what are the things that you can measure that can be shown to have an effect on your system or whatever it is you're doing. And usually after you get past 2 or 3, the other ones are somewhat negligible.
Yeah.
And the more you add, the more you maybe feel a sense of confidence because you've said lots of things.
Right.
But if you think statistically, the more you say, the less likely any of those things are to actually have a substantial effect on what it is you're trying to say they have an effect on.
Yeah. And sometimes we don't need, all these other factors. So, for example, some of my colleagues who by ideology or whatever, they're saying we don't ask questions, right? They meet with a patient, whatever patient shares is good. That's data. How they interact is data, but they don't ask questions. And then they work with a patient thinking that they're treating depression, but they've never asked when was the last time they checked their thyroid panel, and they could be treating Hashimoto in psychotherapy or Graves' disease. It's sort of an exaggerated example to make a point, but then it could be that. There's sometimes concrete things that we must know about to rule it out, there's a famous book about the woman who had a lemon size, hole in her brain, but it was never discovered until her late 20s, until they did the MRI. So, and they could be very biopsychosocial, but she's got a lemon size hole in her brain. So,
yeah. And I'd like the idea of ruling things out as being more, instead of trying to make yourself more certain of what it is you want to believe, just make sure you're not missing stuff. And then the things that remain by proxy become more probable, although not necessarily like all that high probability. But it's just, okay, it's not these things. We know that, so we can focus on something else.
A 17-year-old girl was referred for her first psychiatric evaluation after 8 months of unsuccessful treatment for pain of unclear origin. The immediate reason for referral was the patient's worsening symptoms of depression and new onset of visual hallucinations. The symptoms had developed gradually after febrile illness, presumably viral, that presented with vomiting and diarrhea. Her vomiting failed to resolve after the infection cleared and had led to 25-pound weight loss. No medical cause has been found for intractable vomiting. Relevant prior history included additional gastrointestinal difficulties. She had multiple diagnostic procedures, which were ultimately inconclusive. In the initial interview, the patient did not express any distress about her persistent vomiting, although she did report feelings of overwhelming depression and being scared of visions of people in her room. Her mother, whose primary concern was persistent vomiting, brought a calendar and a diary to the interview that contained detailed documentation of vomiting. It was not learned until sixth visit that the patient's vomiting had started insidiously approximately 6 months before the presumed viral infection. At that time, she had a major conflict with her biological father and decided to stop contact with him. Should I pause here or keep going?
Let's pause here maybe and do a quick summary. So we have the 17-year-old female came in, and you mentioned pain as being one of the presenting problems, but then increasing depression, and then visual hallucinations. I think if someone says that, then like for a psychiatrist, suddenly their mind gets really stuck in one place. Like, okay, well, now I have a limited number of things that I'm considering compared to something else, and also that's scary. So someone's hallucinating, right? But then you mentioned they had a febrile illness, nausea, vomiting, diarrhea, 25-pound weight loss. But then they have this long history of GI workups over time where they've been going and trying to get someone to figure out what is the issue. Reminds me of something like irritable bowel syndrome or something, right? Who knows? But everything has been negative. The medical workups have been negative. The medical, whatever the medicine has been doing, and I'm probably rather extensive studies have not shown anything, I'm going to assume. And then we find out that this nausea especially started long before this presumed GI upset, and it was kind of insidious, slowly getting worse. And around the time it started was also a time she had some conflict with her father that's unresolved.
Mm-hmm.
Okay.
And just to quickly comment, what you and I are doing is we're sifting through the data, which is a lot of data, and we're making sense of it. We're digesting it through what we know, and sort of that's sort of the process, right? There's no surprises so far. I think it's a well-written thing. And should I read a little bit more?
Yeah, go ahead.
Okay. So she also had history of academic underperformance. A school psychologist did an evaluation and before the onset of medical problems 4 years ago, and she did not qualify for special education. The patient's mother decided at the time to homeschool her to improve her academic performance. Initially, they were part of study groups with other kids, but eventually she taught her alone. The patient's social interaction with peers her age has been limited to weekly youth group at church. She reported she never had a friendship lasting more than a month. She's overly sensitive to others' comments and often loses interest in friends after they disappoint her. And I'll read you just a little bit more and then I'll stop. There seemed to be significant enmeshment and ambivalence in the mother-daughter relationship. The patient uses somatization as a way to express her feelings. Although her visions are clearly distressing, they have a phobic rather than psychotic quality. I'll stop here.
Yeah, because those last couple sentences were basically a formulation of one part of the case.
Right.
And the words that were used are very loaded.
Uh-huh.
Right.
Yeah,
Okay.
But here, I think from history, they moved on to trying to explain the symptoms. And when the concept they use, the somatization, is very popular. There's the whole kind of huge field in journals and everything called psychosomatic.
Mm-hmm.
And I struggle with the entire concept of psychosomatic, but then I get a lot of pushback on that. And I often ask patients when they say that the allergy was psychosomatic, I say, explain this to me. So if somebody is specifically allergic to peanuts and not cats, what in their mental conflicts allows them to, use peanuts over cats? And usually people cannot answer that. But
right. And we know there are sometimes very obvious, like biological reasons why people have allergies, but the word psychosomatic suggests that the origin of it is actually more central. Or they might say, sometimes they use the terms like supratentorial
right.
to refer to parts of the brain that are more cortical. And then that supposedly is causing some sort of, or contributing to or worsening symptoms in the more peripheral parts of the body, the somatic parts of the body. Yeah.
Right. And we could build a story, and you're very sophisticated and much more knowledgeable than me that, that HPX is dysregulation. There's a lot of cortisol in the bloodstream, or I don't know if it's in the bloodstream or whatever, and that has effects on the smooth muscles over here. And, it just chronically elevated cortisol kills neurons in hippocampus. We could come up with a plausible story going from this sort of thing to, but again, the whole idea of somatization, I mean, that's a dynamic term. This is one of the psychological defenses. And this is just a story that, why vomiting? Because she somatizes. That's a psychological defense. Also, the story went into a little bit of blame the mom. They're showing kind of like enmeshment between mom and daughter and sort of all this thing. And how the case will unfold later, it will unfold into sort of mom came in the room with an agenda to prove that it's a biologically caused vomiting and nothing else. And she was disappointed when the doctors couldn't find the biological cause. So there's some investment in that. So again, these are frames, these are prisms through which we look at the case and try to make sense of it.
Yeah. And I think what we're talking about here, just to be clear, we're not trying to figure out why this girl, this case, why she's experiencing the things that she is in this podcast. We're talking about the way that people are formulating this case in their minds. Yes. And the things that they tend to gravitate to in order to make a narrative that they feel comfortable with.
A coherent and meaningful narrative for them, the way they were trained. To a psychiatrist, connect the shuffling gait and, rolling pin tremor through Parkinson's disorder is a coherent and meaningful story.
Mm-hmm. Yeah, and it also has some biological basis, right?
Yes.
But when we talk about things that there's these where there's lots of uncertainty, the psychosomatic stuff. Well, in fact, like my last episode, I was talking about psychological scales and screeners, and I was talking about the HAM-D, and how in the HAM-D, which is made in 1960, the Hamilton Depression Rating Scale, some of the somatic symptoms were actually prominently featured in their scale. So they understood that anxiety could cause somatic symptoms like GI symptoms and palpitations, and exactly what we're talking about here was included in a rating scale for depression in 1960.
Yeah. I love short, particularly questionnaires and how they're used with the elevated word evaluation or assessment. Like I assessed the patient, I gave them like a PHQ-9 or something, or depression inventory. And so another good term for them is objective. They're objective. I'm like, come on, you're asking the patient to express their opinion. So this is by definition subjective. There's nothing objective about a questionnaire.
They should call it a numerical estimates or something. Like, it's nothing objective. The reason I made that episode is because we're fooling ourselves. We're telling ourselves maybe this relates to the narrative fallacy, but we're telling ourselves that because a scale gave us numbers and that we can track these numbers over time, it's the more powerful and less arbitrary than if we were to kind of impromptu come up with a formulation outside of that scale. Mm-hmm. It doesn't have numbers associated with it.
But right. So, I mean, I think that the example I gave is certainly imperfect. And, we can say, oh, they're just biased through, they want to, put the psychodynamic, coat on a patient and it doesn't fit whatever. But I'm saying it doesn't matter. I can have stories like that in the CBT world, in the EMDR world, in a specific school of psychoanalysis. I'm just saying this is sort of a occupational hazard, if you wish, that we weave together a story, we make a tapestry, and the patient wants it and we want it. And we tell ourselves that it's temporary and tentative, and we're going to put it aside if the new data comes up, but typically we hold on to that story. I mean, I've attended many case conferences where they talk about repeated patient after a few weeks. I have never seen them saying, oh, my original hypothesis was incorrect, I changed it. Maybe it happens rarely, but there's reasons why. And the more elaborated the story is, the more it's sort of like, if I start putting beef on the bones of anxiety causing insomnia, I'm going to talk about, again, anxiety being arousing, that it's an upper, and all these sort of, I'll bring the chemistry of anxiety and bed nucleus of stria terminalis and all of that stuff. I'm going to sound very scientific, and
right.
The story will seem like beefier, but the core of it will be the same.
Both popular psychology and academic psychology and clinical psychology, all of those things, I think, rely on similar kinds of stories. If you get online and you go to YouTube or something, I have a hard time actually finding academic stuff, because when I type in things that have to do with psychology, I get like 30 videos right in the start of my feed that are someone trying to explain to someone with their pop psychology sort of definitions how to hack their life or what's going on with them. And I listen to these sometimes, and they are often very detailed, very long, very coherent in a lot of ways, and that like it seems like the steps they're taking are logical, at least according to the way that we imagine things nowadays. They try to seem scientific. They try to quote science and stuff. One of the ways we think, one of our biases, is that if someone's including lots of information, if someone is seeming coherent and telling this narrative, it seems then more plausible. But then one of the things I try to tell myself is that the more you include, statistically, the less likely that, in fact, that it's plausible, because all of these things have an uncertainty associated with them. And when you multiply all that uncertainty, you get to almost like zero probability that their explanation is really explanatory, actually. Yeah.
What you said resonates a great deal. I have a wonderful colleague who recently retired, Dr. Loring Ingraham, who's a renowned expert in schizophrenia. He wrote a paper a long time ago about how when we do assessments, psychological assessments, when we include more tools or more questionnaires measuring the same construct, purely statistically, the probability of error increases. Well, the bias in the field is reverse. Why are you drawing conclusions from one data point? You need to have 3 different questionnaires. Often we see it in ADHD world, where there's like 4 different versions of the same thing. But yeah, and it may sound like, again, very critical what we're talking, Ryan, and I just wanted to bring example of where I think the effects of narrative fallacy are minimized. Would that be okay if I read a short paragraph where I think that conclusion was not driven by narrative fallacy more so than other factors?
Actually, I think that would be very helpful. Yeah.
So this is from this peer-reviewed paper. So when a patient suffers from disturbing intrusive memories, which are concrete, timeless, and intense, and a therapist, having connected enough data to suspect acute post-traumatic disorder, can tentatively conceptualize the patient's symptom as a flashback, then they can indeed explain how the flashbacks start, how they operate, and so forth. It doesn't really seem like a big deal, but I'm saying that if we heard that there was no symptoms of, nightmares, flashbacks, hyperarousal, hypervigilance prior to this one event that happened at age 25, then subsequently there's, acute onset condition, intense condition, right? And they're describing to us, because there's neurobiology of a flashback, which is indeed sort of, we re-experience the trauma in a flashback. It is sort of like time is not really working. In the present, we feel what we had felt while traumatized. And all these other things, it certainly, yes, it is coherent and meaningful, but I think that we've collected enough data and the right kind of data before jumping to a quick conclusion from initial data that, to hypothesize why the patient has intrusive, memory of some kind. We could say it's intrusive thought of sort of obsessive something, or whatever, or a psychotic thought. But, to me, this is a reasonable compromise in all the data and thinking to suspect that this is acute PTSD and a flashback.
Yeah, so just because there are narratives and there are logical fallacies and there's the narrative fallacy doesn't mean that like every narrative that we have is necessarily fallacious. The way that you can be more confident is that you're dealing with higher confident prior probabilities. Basically, I'm getting here into some Bayesian stuff because I can't help myself.
Sure.
And I think in the future, we'll probably talk about something called active inference. Today, it might be going a little bit too far for this episode, but I want to bring you back for that. It seems like what you're saying is that because we because we have a story that's not just coherent and internally consistent, but based on, first, there's not a lot of other explanations, right? Because it's isolated, sort of. There was this one event; it wasn't present before, so you can't be adding on. Oh, it could have been something that happened even before that. Necessarily, it seems to rule some of that out. And then the construct itself, you think, is probably a true thing. And so, when you're applying it to a case that doesn't have a lot of extra noise in it, that's not necessarily a fallacy. That's a narrative fallacy. That's more of a, what would you call it? Like a high probability inference. Like,
it is still an inference. Yeah, it's still probabilistic, but I think that we were data driven more so than theory driven. Just I was trying
okay.
to think of, so what can be done. And to me, the big deal is that I'm struggling with, this paper was rejected by 3 journals, and I've got some pushbacks from colleagues as, people say, no, there's no fallacy, or the simple admission that this is the deal, that this thing exists and it affects our clinical work would be a huge step forward. Unless we can be real about it, we can't really make corrections.
I like how you said we were data driven instead of theory driven, and sort of that is a thing that separates the two. I think especially in medical doctors' minds, what is data and what is theory are often, I say the word, enmeshed. They're not really separate things. They're put together. For example, when we're on medicine rounds and we're treating patients in the hospital, instead of, when we give our summary, we use words that are supposed to summarize all of the data that we had instead of all of the data, because that would take too long. But they use those words as data points themselves, right? They use that construct as a data point. So it's, I think it would be hard sometimes to separate out what is data and what is a theory. Like when you gave the example of the 17-year-old female, and then you said there's significant enmeshment between the mother and the daughter, someone might consider that to be data, but the term enmeshment is a construct, right? And so it's not like low-level data. It's like it has a lot in it already.
Yeah.
And a lot of uncertainty inside of the term itself.
Loaded thing.
It's very loaded. So I wonder, how do we know? And we'll talk about this in the future, when our data is more primary data and when it is more theoretically based construct that we're using as data.
There's a lot to unpack here. And, to again be very practical and specific, Nancy McWilliams, her latest book, Psychoanalytic Supervision, I believe is a different method of case formulation than the original ones, where she has 10 different dimensions, if you wish, 10 axes. And they're all psychological, but, and the variables are continuous, not discrete. Because if I go through differential diagnosis tree and I rule out this, rule out that, and I end up in a bucket called major depressive disorder, this is categorical thinking, mathematically speaking. But then I think that her method is more, I won't say more quantitative, but it's more like physics, where you have a phase space with 10 dimensions, and you're drawing a tractor landscape in that. This to me sounds a lot better than just coming up with a story, because stories are deterministic things mathematically, and stories that are coherent and meaningful are very compressible. There's a lot of redundancy in them, and we do that because we're human beings and our work and memory is constrained. If all I've got is this mind, which while talking to the patient, then I have to live with this constraint. I'm not an AI, I'm not a computer, I'm not an MRI. So. And some of my colleagues insist that this is sufficient and necessary, that, I'm talking to the patient, that's enough, and this is all the data I need. Yes, they will look at the medical documentation, but to give a small example of that, there's a debate in the field to have a video camera in the room or not, which is very loaded. There's manufacturers, confidentiality, security, and whatnot, but Beatrice Beebe is a wonderful clinician and psychoanalyst and developmental specialist in New York City. She works with infant mother dyad. There's no verbal language, but there's a lot of motor things happening between the gugus and gagas and the gesture. And what she does is she records a video of mom and a baby interacting, and then she shows it to mom slowly. And she shows attunement on the same wavelength, so to speak, or pace as the baby, or over reaction or under reaction, right? We don't get any of that data, I think, in session. We think we do, because we look at the nonverbals when we work with a patient. We look at the, posture and, pace of speech and, all these other things. But how we collect the data is also important. If we're content with just hearing patients' narrative and talking to them, and that's all we've got, especially on Zoom, then we also narrow the field. So.
Yeah. It seems like what's happening in that situation where it's being recorded, and I don't think we could, for a lot of practical reasons, do that with all our patients and then go back and watch it. And I don't know, actually even know what the value of that would be necessarily. But in this particular case, mother is with the baby, and in that interaction, the live interaction, mom's trying to predict the baby's needs and deal with the baby and trying to figure out what the baby's doing. Going back and watching film on slow motion is going to generate a lot of what I would call error messages in that mom's mind. Now, suddenly she's going to be thinking about the same things, but considering multiple different possibilities as to what that thing could have meant. Whereas in the moment, she just had enough time to get through that moment and move on to the next.
This is a different avenue of collecting information, right? And neurologists, they do talk to the patient. They examine the patient, but they will look at the MRI, which is a different medium of collecting data. They will look at the EEG, which is yet another medium. Maybe they'll order a PET scan if MRI was not too precise or something. And then they put it all together, right? Trying to make sense of it. A lot of dynamic clinicians are saying, no, me talking to the patient is sufficient, and that's it. So.
This has been a great conversation in one way because it's brought up so many questions in my mind. And one of the things I was thinking while you were talking is like it's far different to go from mother baby in the moment, recording that, looking forward and predicting the future, than it is taking a patient who's in your office and looking backward and trying to infer what caused you to be in that particular case. So and then to prognosticate the future, because you can go in either direction, but you can't necessarily go from the inferred past you made from looking at the present all the way to the prognostic future, because you skip the step of the information that's in the present. If that were missing, the narratives help us to fill in all those blanks and make us feel confident that we have this, what mathematically you might call a Markov chain, but we don't really have that. We just feel like we do. We feel like we have connected all these things, and we should just be humble about our own explanations, I think. I want to read what you wrote from Taleb 2007. The narrative fallacy addresses our limited ability to look at sequences of facts without weaving an explanation into them, or equivalently forcing a logical link, an arrow of relationship upon them. It reminds me of some informal logical fallacies, things like the overgeneralization, or the God of the gaps, where you fill in the gaps with whatever explanation. I guess they call it the God of the gaps, because if you find something that's unexplainable, then the easiest thing to fall on is that God was intervening without any actual evidence. But you just fill in the blanks with whatever seems the most likely to you, right? And then there's also something called the sunken cost fallacy. And I think that relates to this concept as well, where you have put so much effort and energy into something that your ability to be objective and say, I should abandon this thing just doesn't exist anymore. You're like, you continue to put more effort into something that's obviously not working, instead of doing the logical thing, which would be to abandon it. Alexey, do you want to, is there anything else we haven't talked about today you want to mention?
I really enjoyed talking to you. I think we have a good energy in this conversation, and and it's spontaneous and flowing. And I wanted to say thank you, Ryan. And I really enjoyed this discussion and the pushback and the comments you've made. And so, but it will necessarily be incomplete, And if somebody wants to, they can read the peer-reviewed paper or other things, and we can certainly talk more. But we just maybe scratch the surface on this vast ocean of.
Right. Yeah, I'll be including a link to your paper in the show transcript at the end. It's at psychiatric.buzzsprout.com. Alexey, I haven't found very many psychologists who, or even other psychiatrists who are kind of interested in some of the things that I am, things like active inference, things like the free energy principle that we'll probably talk about in the future, or Bayesian statistics. These things often seem tangential to what we do. I think they're extremely important for us to understand what we do and why we do it, and to be able to change things and push them in a direction that's maybe more, a little bit more reflective of actual reality. So to meet you, that's great. I'm glad you heard one of my episodes and reached out to me. And if anybody else, is listening to this and also has any ideas, you can go to a form at psychodynamic.com and fill that out, which is what Alexey did.
Yes, I enjoyed it. It's thorough, it's fun, and I'll be sharing it with my colleagues. I mean, your podcasts on aphasia and akathisia and confabulations. I love confabulations. Mark Solms does as well. So I mean, it's a very good balance, and I will say that your podcasts have a nice signal to noise ratio. So.
Thank you. And I hope I express the enough doubt too, that like I'm just saying this and this is me struggling to understand these concepts, and I hope it helps other people to do the same. Thank you for listening. And this has been an episode of Psychodynamic.